So let's do a quick review, if you will, on the initial management of burns. And then I'd like to do a few quick case studies. And then I'd like to tell you a little bit about the burn surge program, which you've probably heard a little bit about. But just by way to put this in perspective, we have about 2 million people in North America, Canada, and the United States that are burned every year. But of that, only about 20,000 require care at a specialized burn center. We're a level 1 burn center, verified burn center actually. There are only about 52 in the entire United States. There are a total of about 130 burn centers in the United States. That's only about 1,500 beds total for the country. In the event of a real disaster, we won't have enough beds. So we'll be into the surgical intensive care units, we'll be in the medical intensive care units, and that's why we try to do some of these trainings from time to time. If you think of trauma, we always talk about mechanism of injury, right? But everyone thinks of burn as one mechanism of injury. You're burned. It's not. Every different type of mechanism here gives you different amounts of heat that's brought to the patient. And whether or not you get a burn is determined by the amount of heat you have, your exposure to the heat, and the condition of your skin and your perfusion of the skin, okay? So if you look at scald, all scalds are not created equal, right? If you're scalded by some hot water that's boiling on the stove, it's going to make it to 212 degrees and that's it. It's never going to go any higher. You're boiling some porridge, some chili or something like that, not only can it get a little higher, but once it gets on you, it sticks, and so the contact time is longer. If we look at the different types of flammable fuels that are out there, they all burn at different levels. Kerosene burning much lower than gasoline, jet fuel burning much higher. And so a short exposure to some of these burns will result in very high BTUs being given to the patient. And if we see a car fire there, it's one of the worst fires that we have because we have a combination of both smoke and fire. A little bit of prevention here. Still, in the higher socioeconomic countries in the world, the leading cause of fatalities of burns is a structure fire, and that structure predominantly is your home. Make sure your smoke detectors work, okay? Make sure your smoke detectors work. Study after study says that either 25% of the homes will not have a working smoke detector, well, they will not have a working smoke detector. And what do you think the most common reason for that is? The battery's dead, right? So change your batteries, and that's why they say spring ahead, fall behind. As we change the clock, change your batteries. California, now you have to have a carbon monoxide unit in your house. You can buy them at Home Depot or at Costco. They cost about $25 to $40. You just plug them into any outlet. But plug them into an outlet close to where you think your carbon monoxide might come from, the garage, the heater, or something like that, okay? This, as I mentioned, is one of the worst fires because a car is basically fire retardant is used everywhere throughout the car. So for the cabin of that car to actually get hot enough to ignite, the fire is super hot. And if you're stuck in that car and being burned in that car, it's because you're trapped, okay? You're either unconscious or you're trapped in there and the fireman got to dig you out. So we see some of our worst patients come out of these types of things, both with 3rd and 4th degree burns and tremendous smoke inhalation. Here's an ounce of prevention here. Look on the left. You see the temperatures of the water. This is the time on the right in which it takes to get to a deep 2nd degree or 3rd degree burn. So think about your hot water heater at home. If it's set on the lower end, it's set automatically about 120 to 124 degrees. That's where it's set at. Every hot water heater you can buy in the United States can only go up to 156 degrees. Thus, 156 degrees is on the chart. So if you crank it all the way up to high, it takes you about a second to get a deep partial thickness to full thickness burn. So put on there your children, put on there grandma or grandpa, put on there someone who has diabetes and a sensory neuropathy of their feet. They get into the water. By the time they realize that there's something wrong, the damage is done. We see we see child abuse more often in this sense, the sense that someone wasn't paying attention to the water temperature, someone wasn't paying attention to when they put the child in there, and kind of plops the child into the bathtub and the water is just too hot. And what is the cranky, finicky kid doing when you're doing that? Probably doesn't even want to get in the bathtub. It's probably kicking and screaming anyway, and you just lift the kid up and you put him in the seat or put him in the water, and you sit down and oh, the kid starts splashing the water up on you. It's, oh my God, this water's too hot. And you pull him out. damage is already done. So we see more abuse issues from that than traditional just putting them in and saying, I'm going to dunk you in this water and cause injury to you. So by law, 120 to 124 degrees is the temperature that apartments and hotels are supposed to be set at, but don't count on that to be the way it is. Because frequently you can't get the hot water out to where you need it, so they put the hot water temperature up much higher, so when it gets out near the end of the line, you still got good hot water in your shower. But the people who are close up on that line have stuff that's very, very hot. Be careful. Remember I said all skull burns are not created equal, so this is your tar burn. We see this coming to Tron Bay all the time, okay? Comes in upstairs to the clinic all the time too. So what we want to know is the story about how this happened, because if this happened right at the trailer where the tar is being heated, the temperature here is somewhere between 600 and 800 degrees. By the time that this is cool enough to mop out on the roof upstairs, it's about 200 degrees. So it's a huge difference in the amount of heat that's going to be contained in this tar. But once again, when you get burned by this, the tar gets on you and it holds the heat in because there's no way you're getting that tar off. You know how difficult it is to get this tar. So essentially you put on a jacket that's 200 or plus degrees on and you wear it. What saves these people is the people that they're working with are smart enough to just grab the water bucket that's near them, their drinking bucket, and dump water on them and try to cool this thing down. So all skulls are not created equal. Same thing when you like a MIVIT report for trauma. We like a MIVIT report, if you will, for burns. We want to know the circumstance of the burn, what caused it. If it's a closed space burn, meaning it happened inside a house or structure like that, we want to know how long they were in the structure. We want to know how much smoke there was, and we want to know what they were doing in the structure. So if they were smart and they hit the ground and they were crawling around and trying to save people and get their pets out, or are they just running willy-nilly standing up, or the heat and the smoke is at its worst. These are important things that we want to do. The rest of the MIVIT report is the same. Kind of a busy slide, but I want you to turn your attention to the far right and the far left here. This is the survivability. 50% here is half will die, half will live, okay? So if you look at lines 2 and 3 here, this is age groups 3 through 40. So the 50% line, in which patients who fall in the age group of 3 to 40 is about a 65% total body surface area burn. Half of your patients will survive, half your patients will die. But look what happens when you're 70 or above. That drops down to just under 25% total body surface area burn. And what do you think they die from? Their comorbid disease, their underlying coronary disease, their pulmonary disease, they have a myocardial infarction, they have rhythm disturbances, they get acute on chronic renal insufficiency, and they have complications, and they die from complications of that, as opposed to actual burn. Burn's looking good, we excised it, we grafted it, it's looking great, and the patient still expires because they had a myocardial infarction. Let's just quickly review some of the types of burns that we see. Histologically, here is the epidermis. This is the layer of live cells on your skin. This separates you from your environment. The brown layer above that is the white stuff that you see flake off when you take a shower in the winter. Those are your keratinocytes. They used to be live epithelial cells. They're marginating out. They actually form the first outer barrier of your skin. This area through here is the dermis. The dermis is where you have all your elastin, all your collagen, gives you the toughness, the ability to stretch your skin, and other types of mechanical properties that you need to make your skin not rip all the time, okay? If you look at some of the elderly patients who fall and they hit their skin and it just like degloves off, they have very poor epidermal dermal junctions and very poor dermis. And this is just what happens as we age. This all changes. Actually, as we age, this dermis gets thinner and thinner. And so when you look at the elderly patients, you say, boy, you have kind of onion thin skin. That's why it's like that. But the important thing in the dermis, besides the arteries and the nerves that are in there, the things to regenerate your skin are there. And each one of the hair follicles has epithelial cells lining the hair follicle. And so when we talk about healing from a second-degree burn, it not only heals from outside to in, but all these hair follicles begin to repopulate and push cells back up onto the skin to help it heal. When it gets burned deep enough that these germinal cells centers are injured, you no longer can heal that way, and most likely you need to have skin grafting. And of course, the third-degree burn goes all the way through the dermis and into the fat tissue. Fourth degree is fat and muscle, etc. Now, all sunburn is not first degree burn. If you come in and you've got a bunch of blisters on, it's second degree burn, right? Second degree burn equals a partial thickness burn. So all sunburn is not first degree burn. It's just a mechanism of injury is ultraviolet light. The degree depends on how you look when you come in. This is a typical pull-down scald on a child, and why it looks like a pull-down scald is you can envision a child putting his or her arm up and pulling something down either off the stove, off the counter, or off the table, okay? It drips down on the side of their face. They're very smart and very quick. They look away. They don't look into it. It doesn't surprise them, probably because it's hitting their arm first. So it's on the arm, side of the face, either down the front or the back of their torso. This is a typical look of an unintentional injury, okay? This is not child abuse. This is a bad thing happened at house. Ounce of prevention here. Do not have your kids playing around in the kitchen. It is not an area for them to be playing. Have a zone right around your oven that's about 3 foot wide that they cannot go into. We see too many kids put their hands on the oven door comes down, put their hands on the inside of that, and those are potentially preventable incidents. The other thing is if you have small kids, you cook on your back burners, you turn your pot handles in towards the wall. You don't put anything on your table until it's ready to be put in the mouth, okay? It's got to be cool enough to eat by the time it goes into the table. So no soup goes onto the table to cool off. Everything that's cooling off on the counter is in the back, and they'll still get into this stuff. But they'll get into it less than if we do what our present things are. This is an adolescent that has an injury to the back of the hand, touching a older oven door. You can pretty much touch them now, the new ovens, and hold your hand there, and nothing's going to happen. But the older ones, even with the windows in the 70s, you could still put your hand up there and get a burn. And so this is a large bullseye. We don't know how deep this is. It's at least a second degree burn, and it's probably a deeper partial thickness burn. This is a deeper partial thickness burn. It looks dry. There's some sylvadine on there already. But the difference between the superficial and the partial, when you look at it, is the superficial is pink to red. It will weep water or exudate. It will look alive to you. The deep partial thickness have more paleness to it. They tend to be drier, and they just don't have that real alive look when you look at it, to suggest it's a much deeper injury. This is a child who was sitting in a high chair, and she pulled her soup over, and the parents got her up pretty quickly, but unfortunately the diaper and the pants that she had on held the heat in there a little bit longer, so you see this type of wound, and it looks fairly pale. Fortunately, though, this one healed without surgery, but this is a deeper partial thickness burn. The question is this child abuse or not? So you have to go through the history. You got to kind of quiz the family and kind of understand what really happened. And the story really fits that this was an unintentional injury. Little girl put her hand up on the back of an iron, deeper partial thickness burn. This is another girl that put her hand onto an iron, and what you see here is the bullseye has already ruptured, but when you think of that other bullseye that we saw, still had normal skin color to it. This is a white skin color to the bullseye, and that's because the tissue underneath here is very pale. Once you take this dead tissue off, you're going to find a very pale wound. It's going to be a deep partial thickness to full thickness. See how it's on her fingertips like that? If it's an intentional injury, as a general rule, the hand is a tattoo because somebody pushed their hand onto whatever it is that was hot. So it's not just your fingertips that are burned, but it's the whole finger that is burned. It's the whole palm that is burned. This is the look more of an unintentional injury in this child. This is a full thickness burn. This is a full thickness flame burn, so it looks like flame. But everything that's full thickness doesn't look like this. We get some people who come from the Navy or from the NASCO shipyards that are working on steam, and a steam full thickness burn actually looks very, very pale. If you think about cooking a lobster and overcooking the lobster and how it kind of gets this white look, that's what that looks if it's due to steam. What do you think this was from? This is an adolescent, probably about 14 years of old, who came to us with a story that didn't make any sense at all. What do you think happened to him? First of all, he's a male. He's 14. What does he like to play around with? Fire. Adolescent males love to play with fire, and they like to make little fires bigger and big fires bigger. Okay, so he had some gasoline. He and his buddy had some gasoline. They had a bonfire going. His buddy had the gasoline. They wanted to increase the flame, so his buddy threw the gasoline onto the bonfire. Unfortunately, some of the gasoline went through the bonfire and lit up, and then lit on this child. So he has a gasoline burn. You can kind of see the splatter and get an idea what this looks like. This is a couple days old from the burn unit, and you can see this is just dead tissue that is on here. This is the Pseudo SR. It's a combination of white cells and dead tissue. This is all 3rd degree and needs to be grafted. So just a couple things about burn resuscitation. It's a little different than trauma resuscitation. We don't have any blood loss, right? We have a loss of volume from the intravascular space into the interstitium, and we have that because there's a systemic release of cytokines and mediators that cause the capillaries to leak. And when the capillaries leak, the fluid goes in the interstitium. That's why they swell up. We see that at the level of about a 20% total body surface area burn and above. So under that, we usually don't see that, okay? But over that, it's pretty predictable as to what happens. So here's a little schematic, and this is just a drawing of a capillary. If these would be the tight junctions of the capillaries. When things are released from the burn, particularly tumor necrosis factor, these gap junctions open up a little bit, and the fluid can move out easier into the interstitium. So what does that mean to you when you resuscitate the burn patient? It means they don't need 2 liters right when they walk in the doorway. If they just were burned and they're 20 minutes out from Chula Vista or something, they just need to have their Parkland formula started up, and they'll probably do fine. If they've come from Calexico or Mexicali or something like that, and they're 5 or 6 hours out, then we are behind, and then we actually have to make up those hours that we're behind. But we make it up over an 8-hour block. So if somebody comes in and we figure out our Parkland formula and they're supposed to get 8 liters in the first 8 hours, and they didn't get anything for the first 4 hours, they're actually going to get now 8 liters in the remaining 4 hours. And so we do it that way. We don't bolus them with 4 liters in the first hour and then move on. We just go ahead and add it on to our thing. So your approach is somewhat different. We use hypertonic saline, but it's not something that you need to start in the trauma bay, okay? You can just hang lactated ringers, and if it calculates out to 1 liter an hour, just turn them on a liter an hour. Now, all things can fall by the wayside. If the patient comes in, maybe it's an elderly patient, maybe they're on diuretics, they have inhalation injury, you've got to intubate them. You may need to give them a little fluid bolus to get them through the intubation, the induction, and all that stuff, okay? Just you have to think about what's going on with the patient versus a 20-year-old who can take that intubation, it's not going to drop their pressure, et cetera, et cetera. You remember a few months ago, we had that elderly patient in there and looked like she was having a darn MI in the trauma bay. Everything we did to her was resulting in hypotension, tachycardia, dysrhythmias, etc. As it turned out, she was having majorly cardiac dysfunction. So like I said, older people, comorbid disease, her burn was under 25%. She ended up expiring on us, okay? Maximal edema usually occurs somewhere between 12 and 24 hours on the smaller burns, but the bigger burns, the 50, 60, 70% burns may go on 24 to 36, and the real big burns may actually be 2 days worth of resuscitation. So we just have to watch that. Simple Parkland formula, it's 2 to 4 mLs times the weight of the patient times the percent burn, okay? Easy example of this, 100 kilogram male, 50% burn, 4 mLs, so that's 100 times 50 is 5,000, times 4 mLs is 20,000 mLs in a day, okay? So that's 20 liters in a day. Half of it's given in the first 8 hours, so that's 10 liters in the first 8 hours, about 1.25 liters an hour. And that's how we simply calculate it out. That's based on 2nd and 3rd degree burns. 1st degree burns, who cares? You just got to drink your own fluids and juices to take care of those things. So we don't add those into the mix. Real important for children. We kind of arbitrarily put the rule at about 2 years of age, although this is a problem that's really particular to under 1 year of age, but we try to catch the outliers. Kids' brains run on what type of fuel? What type of fuel do you need? fats, carbohydrates, proteins, carbos, okay? A kid's brain runs on glucose, and so you need to have glucose in there. As a matter of fact, a kid's liver, which is the area he or she's going to use up the glucose in the serum, then he's going to start taking glycogen, making it into glucose in the liver, and then he's going to run out of glucose, and that's in about 4 hours, okay? That's their maximum stores. So you need to be having a glucose. So if we go ahead and we resuscitate the child with the standard Parkland formula, we're also giving in another IV, their maintenance IV, in the form of dextrose. It's usually D5 normal saline. So they have two IVs. They'll have a D5 normal saline or D5 half normal running, and they'll have their resuscitation fluid running in the other one. So that's something that you should remember, because it's possible that a little kid might get stuck in the trauma bay for a little bit if we don't have any beds upstairs right away, and you know, things are just going quite slowly. We need to get glucose running in kids. So we say everybody 2 and under gets it, and that way we make sure that everybody who may have the problem won't have the problem. Delays in resuscitation usually result in a deepening of the burn. It's just like a delay in reperfusion of a cardiac injury or a cerebrovascular injury. If you don't reperfuse the area, the zone of injury extends, okay? So we need to get them adequately resuscitated. Additionally, inadequate resuscitation can result in problems such as acute kidney injury. We do this, we monitor the resuscitation the exact same way you do in trauma. We look at pulse, we look at blood pressure, we look at pH, we look at base deficit, we look at lactate levels, and we just follow them. The one thing that is different than trauma, usually in trauma, your hematocrit is going down. In our acute phase, hematocrit is going up because we get behind the resuscitation when they first come in. So if your admitting crit is 40%, maybe at 6 hours, it's actually 45 or even 50% as we fall behind. But as the resuscitation begins to catch up over the ensuing 6 hours, by the time we hit 12 hours, we usually see our hematocrit going down. If our hematocrit stays up, we know we're still under-resuscitating, we're undershooting. So while we use urinary output as a good marker of resuscitation, a half to 1 ml per kg in an adult, it might not be by itself, it might not be an accurate surrogate marker of adequate resuscitation. So we've got to look at everything. Same thing you do with trauma patients, okay? The principles of wound care: stop further burn injury. So where is that really important? By the time it comes to us, most of the burning has stopped. A chemical injury may not, okay? Most fire departments will lavage the patient before they get here. We still try to lavage them when they get here if it's a chemical injury, okay? Just so we make sure that we know that they were adequately lavaged. We clean the wound up. We debride bullae that are bigger than a quarter. We just take them off. Probably in the burn unit, we take every bullae off, no matter how small it is. We will perseverate on that bullae until it is gone. But for your thinking, a quarter or smaller, you probably can leave alone. And we cover the wound with a antimicrobial, topical antimicrobial of some sort, and we put a bandage to keep it separated from the environment. And our two main principles are to prevent desiccation or drying out of the wound and prevent infection from occurring on the wound. We don't give systemic antibiotics unless you have a cellulitis or a wound infection, okay? The topical antibiotic, the silver product that you put on there in Silvadene, those should all do fine in most cases. If you look in your PICSs or in your emergency room, that blue jar of Silvadene is what is always stocked in there, okay? That's tried and true. It's a bit greasy, but you can always put that on your second and third degree burns, and that will do well. You can also use just simple polysporin or triple or double antibiotic and put that on your wounds to try and keep the bacterial counts down. We use collagenase. This is something that you're not going to put on in the trauma bay almost ever. The collagenase, which is santal, is an enzymatic debriding agent that just helps us to take care of the burn wound by essentially eating up and digesting collagen and tissue. So it's an active chemical debriding agent that you put on the wound. Just some simple pictures there. Upper left, you see the bullae coming off after it's been washed. You see some Silvadene going on, and you see the large burn bandages. So whatever difficulties you think you might have in the trauma bay of bandaging these patients up when you have to bandage them. And most of them you just send upstairs, just put some clean towels or sheets or Curlex on the wound and send it upstairs. But occasionally you have to actually bandage down there. When we go out and teach this to the other trauma centers in town who have none of the big equipment that we have, the big burn bandages and all the big zero forms, it's quite an ordeal to actually do some of these bandages using little ABDs and little 4x4s and trying to get the patient bandaged. So we're pretty lucky here. I want to talk just a little bit on smoke inhalation, and I know I'm going kind of fast because I'm actually running out of time here, but there's a few more things that I want to tell you even after smoke inhalation. So if you take a look at this guy, big time stigmata of smoke inhalation injury, right? He's got a burn on his face, he's got soot on his face, he's got edema already on his face, and luckily he's got an endotracheal tube in his mouth. But if you think of smoke inhalation, there are really three main components of smoke inhalation. There's a thermal component, there's a particulate component, the smoke itself, the soot particles, and there's the toxic metabolic byproducts of the fire itself, carbon monoxide, cyanide, various other hydrocarbons, okay? Three main types. Which one of those do you think is the most common? The particulate one. So if you look on the news every night, you see that when there's a fire in town, there's usually always a shot of somebody who is sitting in the paramedic truck with a high flow oxygen and getting a beta nebulizer. Okay, that's just the most common, and you treat it just that way, oxygen and beta nebulizer. The worst of them is actually the toxic metabolic byproducts, so carbon monoxide poisoning, cyanide poisoning. And the one that's in the middle but is also a bad actor is the actual thermal component. When you have heat getting down into the glottis, distal to the glottis, and actually causing burns of the trachea and the lung tissue. Well, if all these people are in these hot fires, why do they not have more thermal burn injuries? Well, it's because we have evolved as a species, and it's not just us, all the species have evolved to try and cool hot air as you breathe it in, and to warm, cool air as you breathe it in. So you breathe through your nose, you have your concha, you have your nasal hairs, you have all that redundant tissue, that peritonsillar tissue, that is either taking heat out of hot air that you're breathing, or heating cold air that you're breathing. But by the time it gets to your vocal cords and down, that ability is lost. So whatever you're able to heat or cool going from here to here, now the final temperature will get to the lungs. And so usually it's patients who have long exposures to a fire, or patients who have short exposures to a very hot fire that end up with the thermal injuries and actually burn the respiratory epithelium. Those are very tough patients to have to deal with. Again, you can see stigmata, you see soot, you see flame, you see some edema around there, and you see that he's already intubated. You see problems with hypoxemia, VQ mismatches. You see problems with increased pulmonary resistance, and that's a problem in elderly patients who already might have pulmonary hypertension because of some heart failure. So it exacerbates all those things. The total surface area of your lungs is about the same as the total surface area of your skin. So when the lungs are injured, there's an increased need for fluids and fluid resuscitation, so they end up getting very, very edematous. The more fluid that they have in the lungs, because the lungs are injured, just predisposes you for acute lung injury type of problems to occur. So let me just go really quickly here. These are just some pictures. This is some injured epithelium of a bronchus. You can see it's very erythematous. These pictures on the right and left are just the thick, tenacious sputum that comes out of these patients as they begin to slough the respiratory epithelium. And while with your Ballard, you might be able to get into the right main stem and get a little of this off. This is something where we use the pulmonologist to bronch these people almost on a daily basis until we clean this out. Because A, they can go into directed areas of the lung, get into the left lung, and B, they'll just lavage this and try and flush this off the walls. So pulmonary toilet here is a mainstay of this type of care. Let me just talk to you a little bit about carbon monoxide here. So carbon monoxide, colorless, odorless, tasteless gas. It displaces oxygen off the hemoglobin. It has an affinity for the hemoglobin that is huge. The half-life of carbon monoxide on room air is about 320 minutes. If you put them on 100% mask, you can have that, okay? You can really help the patient out. And that's why we ask every paramedic these questions. If you suspect a patient who has closed space burns, and they have a risk for smoke inhalation, you just put them on a high-flow, non-rebreathing mask. But from the time you pick them up till the time you drop them off, and we'll get the carbon monoxide levels here. Because if it takes 30 minutes to get up from South Bay or something like that, they've already got 30 minutes of the right therapy going on. And if they didn't have the injury, so what? We wasted a little bit of oxygen on the way. So we go ahead and do that. We dive our patients in the hyperbaric chamber if they're stable, if their carbon monoxide levels are greater than 25%. And the reason we do that is because carbon monoxide poisoning can kill you, but carbon monoxide exposure at high levels can cause your brain not to work. And it affects your cognitive ability. And what we're trying to do with the carbon monoxide is not try to drive it and clean up the blood and have a good blood level of carbon monoxide. We're actually trying to drive the carbon monoxide out of the CNS tissue. And so that's why we go ahead and do that. If you look here, the concentration of carbon monoxide of 10% or less, someone who smokes 2 packs a day probably has a CO level 6 to 8% just walking around. That's just normal. There's no symptoms at 10%. Just put them on some regular oxygen and they'll blow it off. But you can see by the time you get down to 40%, you start getting into trouble, okay? And just like everything else, the younger you are, the more likely you are to be able to tolerate these higher levels. But you take somebody who's 50, 60 years old or older and give them a 50% carbon monoxide level and you're off to the races, okay? When you see these guys show up in the trauma bay and they're in full cardiac arrest, those levels are usually 70 or 80% carbon monoxide when they come in. And so when we do get them back after we do codes on them, if that initial level is usually over 50, we don't have survivors. I mean, we can get them to live, but we don't have any meaningful survival rate, and usually the family will withdraw once they see that this is what has happened. But just something to think about. And I want to switch gears now. So this is the San Diego County Burn Disaster Plan. You know that in the county there's something called Annex D, which is a set of rules and regulations that talk about trauma disasters. There was never a burn disaster plan until about a year and a half ago. And the county came to us and said, we probably need to have a burn disaster plan because it's a good idea. But more importantly, the Health and Human Service Department of the feds said, if you want to get some of the money that's going to get passed out to improve trauma systems and burn systems, you need to develop these plans. And so everybody kind of got on the bandwagon. So the American Burn Association reviewed all major disasters, fire disasters in the United States for the last year, 100 years. And about 25 to 30% of those involve burn patients, okay? So, and if you think about it, it makes a lot of sense. You know, a tornado usually doesn't do that, but the tornado that then kicks off the gas main that then causes a fire results in burn injuries. As I mentioned to you, there aren't a lot of burn centers around to take care of these patients, so it's likely that you'll be taking care of them with us. This is the same as an injury pyramid, and it just is the amount of patients that fall in these groups. Fatalities are always the smallest portion of injury. So fatal burn injuries is the smallest portion of this most of the time, but not all of the time, okay? So when we have a factory that explodes, we have a whole lot of fatalities, burn fatalities. When we have plane crashes that crash, we have trauma and burn fatalities. You know, we usually don't have a lot of survivors. So that's kind of the opposite of this. 30% TBSA is kind of the tipping point here. It's kind of a national benchmark. Everything that's greater than 30% will come to UCSD, but everything that's less than 30%, if we're really overrun, will be going to other hospitals, and I'll outline that for you. So burn surge is the ability for us at the university here to be able to increase our capacity. You surge every Friday and Saturday night in the trauma bay, right? You have 4 bays. Suddenly we have if you look at it, instead of 100% busy per hour, sometimes we're 150%. You're just moving them through faster, and someone's in that same bay within the same hour. So we have 10 floor beds and 8 ICU beds. During the 07 and 03 fires, we doubled our capacity, okay? But that means we're all over the hospital. So we're down in your unit, we're down in up in the MIC unit, and we're all over telemetry. But that's about the maximum that we can handle here at one time. We just don't have the staff and the resources to still give the patients adequate care if we go over 40, okay? We hit 38, 39 during the last one, and really, we are living on the envelope with that. It's very difficult to do. So we have to have a way to offload some of these patients. So is there a reason to do this in San Diego County besides the feds asked us to do it? Well, sure. Here are some of the things that have happened. Back in 2010, there was an F-18 crash up in the UTC area, one down in a residential area. One family was completely wiped out with this. But had this landed somewhere else, had it landed near a school, had it landed in a shopping center, it would have been a whole different story. Back in I think it was early 90s, PSA flight crashed over North Park. No survivors from the crash. Some survivors on the ground with surrounding burns. This occurred, actually it was 207 and not 208. This was the 207 fire. So this is a small plane landing right up here on Montgomery Field, just north of Sharp Memorial. Missed the runway, ended up on the 163 and crashed into the barricade in the middle. Pilot and passenger walked away, and no cars were involved in this. But you can see how it can kind of happen. Hotel explosion, 2008, remember that? All these guys came to the trauma bay. There were like 6 of them who showed up one day. This was a gas leak that was associated with some electricians who were doing electrical work. So there's a natural gas leak that they were in. They were in this room. The wires they were working on sparked, and poof, the whole thing exploded. We had 6 people from that. And we have the 2003 and 2007 wildfires, in which we take around 50 patients get sent to us, and we usually admit between 20 and 25 of those patients. So those are huge events when they occur here. They're somewhat predictable in that they will happen again. Hopefully each time they happen, they'll be less and we'll be able to take care of them better, but we still have to be ready to deal with. So we talked about what our resources are, but on a regional level, we're the only game in town down here. We're the only burn center in San Diego County. We're the only burn center south of Orange County. Everybody else is in Orange, LA, or Riverside County. So Arrowhead's got a small burn center of about 15 beds. There are probably about 60 beds between all the hospitals up in the LA basin. So what we have are regional and statewide agreements with a number of these hospitals to move patients out of UCSD in the case of a disaster. And our main routes out of here are our brother and sister UC institutions. So UC Irvine and actually all the way up to UC Sacramento up in Davis are our main lines of communication and sending patients, because we're essentially the same hospital system. So the whole legal and the whole financial component of it is all wiped out because we're the same system. But USC has agreed to participate. Arrowhead has agreed to participate. The Grossman Burn Centers don't participate in anything unless you've got, cash to pay. So, and the Arizona Burn Center over here is one of the biggest burn centers in the United States, and they are a big player. So if we have to move people, these are the ways that they're going to go. We talked about this. Let me just go to this slide. The ABA has, in that review of the last 100 years of disasters, figured that a community, an urban community, should be able to prepare for 15 potential burn beds, burn injured patient per million people. For San Diego County, which has about 3 million people, that's 45 patients. We can almost handle that. We're within a few patients of doing that all by ourselves. The federal government, unfortunately, doesn't agree with that. And the feds wanted us to prepare for 50, not us, the whole country. All urban centers have to prepare for 50 patients per million. That's 150 patients. There's no way UCSD can take 150 burn patients, all right, today, tomorrow, or the next day. So we had to come up with a huge plan on how to do that. So how do we go ahead and do that? So we still remain the primary burn center for all the big badness that comes in because the hospitals just can't take care of that stuff. But what we utilize is our existing San Diego trauma system as a second tier level of burn receiving patients. And remember I said 30% is the cutoff, so if you're under 35% TBSA, if you just have a smoke inhalation injury, and we are in a burn disaster being defined by the county, how does that happen? Incident command goes to a scene, something has happened, they usually call us right away and tell us what they're looking at. We'll call the county and say that we have an incident that seems to be going on, such and such exploded down by the Navy Yards, and there's an anticipation that there may be 50 to 100 casualties. We'd like to go on to burn trauma, Annex D bypass equipment, not bypass, erase that word. We like to enact the annex, trauma and burn annex. That will stand up everybody. So now what happens in the emergency departments on all the radios is the county sends off a message. Major trauma in San Diego County, major trauma burn San Diego County, Annex D is now activated. Expect trauma and burn patients at designated areas following the plan. So that means it's payback time for radies. For all the times that they go on bypass, they get the call and says, you're gonna get kids, okay? You'll get burned kids. Every one of these others get a call and says, you know, you may start receiving burn patients. And then from the field, they are triaged. Everything 30% and bigger comes to UCSD, and the smaller burns start getting triaged, just the way we triage a big crash on I-8 where there are 20 people that need to go places. Some come here, some go to Mercy, some go to Sharp. You know, that whole thing starts going, how many can you take? Can you take another? Can you take another? But that's enacted. There's a third tier of this that I hope never we have to activate. But it's all larger non-trauma medical centers. The Kaisers, the Navy, Camp Pendleton, Tri-City, Scripps and Sharps and Chula Vista and those things. So what did we do to try and help out with this besides make the rules up? Well, it's a 72-hour plan, and that is every disaster, whether it's a burn, whether it's trauma, tornado, hurricane, the federal government says you have to be prepared to take care of your own community for 3 days. If you look at Katrina, it's even longer than 3 days, right? Before the National Guard finally shows up and starts driving their trucks in. You can't get the equipment in fast enough. You can't move the patients out fast enough. So we have a 72-hour plan that says if a patient goes to one of those other hospitals, they have to be able to take care of that patient for 3 days. At the end of 3 days, we will do our best to get them back into UCSD if they still need ongoing care, or we'll move them out of the region to one of the other hospitals. And we will act as the resource center for moving those out. So we don't want Palomar to be calling UC Davis or USC. We want Palomar to keep in touch with us and say, I still have 3 patients over here. They all need hospitalization. What are we going to do about them? So we'll take care of it that way. So in the meanwhile, we hope that after we get through the initial influx of patients to UCSD, we can absorb a few more patients, kind of onesies and twosies, and get them back over here. Just back up 1 second, and I'll tell you what we created to try and help these hospitals out. Remember that initial graph that I showed you way back about survivability? This is it looking at a different form. And so if you look here on the left side, you get the age groups. If you look across here, you get the total body surface area. And basically here you can see that less than 10% burns in most age groups are treated as outpatient. You can see here how in the bigger burns, the mortality rate is much higher. So in the 70 and plus, a burn only 30% has a low probability of survival. If you're a youngster, 2 years of age up to 10 years of age, you can get yourself out to. So this gives us an idea to try and help figure out where the survivors are and where the survivors are not, and especially in the case of a disaster. This is a stout adult triage unit that is used by our present pre-hospital paramedics. We are modifying this with them to do burns in here, because this is a trauma triage. So here's what they ask themselves. Are there spontaneous breaths being taken by the patient? Yes or no? If yes, what's the respiratory rate? Less than 30, you continue down here. Greater than 30, they become an immediate patient. If it's less than 30, are they perfusing? And all they do is just check the radial pulse. Radial pulse present, radial pulse absence. If the radial pulse is present, what's their mental status? And they simply just ask them to obey commands. They don't care if they're oriented, if they know their name or anything. You know, move your hand, yes or no. This gives you the different types of triage tags that you're going to get. This is what gets put on the patient. So this is what you'll see coming in from one of the burn disasters or one of the trauma disasters, okay? And so what they do is each one of these is perforated and they tear off till they get to the one that is you. I kind of think there's a little fallacy in that, you know? Like, if you happen to get caught on your tag and your tag gets ripped off and suddenly the only thing that's left is black and you're really a yellow, you're hosed, all right? Because you're gonna go see the priest instead of go get the care that you need. So this is what we developed to help the hospitals out. We developed 5 specific educational modules. These modules talk about how to do different things. There's a written manual. We've gone out and done 2 train the trainer things for countywide exercises, and we go out to multiple hospitals all the time. We're going out to Palomar in a few months. We've been over to Mercy, been over to Rady, and we just take all this material with us, and we try to teach them. I'd like to end with that. I'd like to say I hope that I gave you a quick review, if you will, on the initial evaluation and treatment of the patient, because that's what you see most of the time, to give you a little bit of understanding of the different mechanisms of injuries and how to think about them as to how much heat it's going to bring to the table, if you will, and how much the potential for burn injury is based on that. Talked a little bit about smoke inhalation, particularly carbon monoxide, poisoning, treatment being 100% high flow oxygen. I didn't mention this and I'll do it now. Cyanide poisoning actually is the leading cause of fatalities from toxicity of smoke, metabolic byproducts of smoke, and now we've got a great antidote for it. Used to be we had to give the amyl nitrate to the people, and now we give cyanocobalamin, the cyanokits, and it's actually a vitamin B analog that we give. So it's pretty innocuous, but it makes the urine purple, but we can just go ahead and give it. So when you think of cyanide poisoning, you think of profound metabolic acidosis without a good reason for it. Okay, their base deficits remaining very negative, their pH is bad, and you don't have a good reason for it. Okay, that's probably cyanide poisoning until proven otherwise. And now all we got to do is give them, the kit comes from pharmacy, you just hang it, you run it in about 30 seconds, and that's it. The treatment is done, okay? So just think about that. And then I wanted to introduce you to the burn surge concept, okay? So we just had our second rain of the season, so maybe we won't see the fires this year, hopefully, but we are right at peak fire season right now, but hopefully we'll squeak through till next year. So just so you know that. So thank you very much. I know that I'm a little bit over right now, and thank you for allowing me to come talk with you. So see you later.